Welcome to Heartland Rehab Podcast, where we break down health, recovery, and performance with some of the best minds in healthcare. And today we're diving deep into knee preservation and how we can protect our knees, delay surgery where possible, and make better decisions when knee pain starts showing up. And so joining us today, we have Dr. Hamid Razak, a consultant orthopedic surgeon with over 15 years of experience, currently practicing at Total Orthopaedic Care and Surgery. Dr. Hamid's clinical focus is on knee injuries and knee conditions, spanning everything from early intervention and knee preservation all the way till knee replacement surgery when needed. So some of you may also know him outside the clinic. He's involved in community work as the advisor to West Coast Jurong West GRC grassroots organization, bringing a broader public health perspective to how we think about healthcare access and education. And of course, joining us as well is Bala, co-founder of Heartland Rehab, with over 10 years of experience in musculoskeletal physiotherapy, helping clients preserve and optimize both their physical and mental well-being throughout their lives and sporting careers. So, Dr. Hamid, thanks so much for coming down today. Before we start, I want to learn just a little bit more about you. So, how did you get interested in orthopedics?
Well, it's one of those things, in school when you are good at a subject, and you don't have to spend too much effort studying for it or fretting over exam results, you tend to enjoy it. Orthopedics was one of those specialties. As a medical student, I just found a natural inclination towards the concept of orthopedics, into the theory behind orthopedics. And I guess also as a bit of an avid sportsman myself, seeing athletes being treated during my rotations, drew me towards a specialty. And I guess I also have a little bit of an engineering mind. As you know, orthopedics has a lot of mechanics, a lot of engineering principles. So that kind of drew me to the science of orthopedics. And then, of course, treating athletes, learning about sports injuries, sports biomechanics, got me really intrigued into the academic aspect of orthopedics as well. So I would say it's a very all-encompassing, has a little bit of everything in it, from the actual fixing and doing the surgery to learning about injuries and sports science, and also engineering principles and research to make surgery better, faster, and simpler.
During your time working in the public sector, was there any particular research that you enjoyed doing the most? Was there one that really resonated with you?
I think I went through quite an evolution in terms of the type of research that I did. As a resident in training, there's very little time for us to do what I call primary research, which means setting up trials and running the research yourself. What I did a lot, in fact, half of my publications, if you look at it, were all audit type of research, where we had great outcomes collected at the hospital I was training in, and thousands of patients went through the system, and we used those data to study the outcomes of particular surgeries, or we could compare A versus B and basically do comparative statistics. And because we had the benefit of large volume, the data was very robust, and the research outcomes were very telling. And I was very lucky to have supervisors who were invested in your own development, and it gave me fantastic opportunity to be able to write up papers as first author, go overseas to present this as posters and oral presentations. It's a fantastic experience, which then led into the next phase of my research when I was a junior consultant, a little bit more independent, where I was then doing independent research, setting up either prospective studies or even basic science studies on my own as the principal investigator, and then getting junior members of my team to be involved. And it was kind of a nice cycle, because I was in their position several years prior, and now to take on the mantle of being a mentor to guide the next generation was a pretty nice thing.
So within the field of orthopedics, what was your primary interest?
I would say initially, as I mentioned, it was mainly just audit-based research, and I kind of honed in on the knee after a while, primarily because, number one, it's the most prevalent joint that's injured in sports, I would say across the world, but particularly in Singapore. And even if you look at degenerative conditions, all over the body in Singapore, the knee is one of the more common. I'm sure Bala would agree with me as well. Knee arthritis is just more common than hip arthritis, for example, in Singapore, as opposed to Western countries. So I thought that is something that our people need, right? Expertise in treating knee conditions. So I kind of zeroed in on it, and my research followed suit as well, because you want to be able to translate what you research into clinical practice. So it made sense that if I was going to be a specialist focusing on the knee, then my research should also be focused on the knee, so that I can form or develop a deep interest and deep expertise in knee surgery.
Funnily, I actually have a knee injury as well. I have none of my body parts have been injured. It's only just my knee.
Yeah.
And actually, I had to see a physio for that as well.
Yeah, they do wonderful work in keeping them, away from people like me.
All right, thanks so much for sharing a little bit about yourself. What about you, Bala? How did you get started on and interested in musculoskeletal physiotherapy?
Yeah, I think similarly, I always had like a passion for medicine. And I found out about this physiotherapy course through a friend, actually, when I was still post-JC, just figuring out what to do, which courses to apply for. And I just thought, give it a go. Actually, it was only then that I went to read up on what physiotherapy is, and found that it was quite an interesting field to be in. Applied and got in, studied, never looked back. I think it's been a great journey so far, helping people, just making an impact in people's lives.
Dr. Hamid, you mentioned that the knee is one of the joints that is primarily injured for Singaporeans. Do you find like that's the case as well in your physio practice?
Actually, yeah. So we did do some back-end statistics work within the type of clients that we see in the private setting, and we found that actually the most prevalent one is knee conditions, and they tend to stay with us the longest. Be it they tend to be maybe post-surgical, they tend to have maybe more care needed to go through like the whole process of recovery. They tend to stay with us longest, and they are the most prevalent as part of the population. Yeah.
Right. For the both of you, are the people coming in usually athletes, or do they tend to be everyday individuals?
Well, for me, because I don't primarily see patients of just a certain demographic or age group, I kind of tell people that I'm a cradle-to-grave knee surgeon, right? So I see patients from all spectrums of all ages. So I tend to see across the board young athletes, or even amateur sports people, or just people who are what we affectionately call weekend warriors. They just participate in sports over the weekend just to keep fit. So that's one group. Of course, we have the acute trauma, right? Those who get into injuries, they may not be particularly active in any particular sport, but when they go on holidays, they might take up skiing, for example, right? And they get injured while skiing overseas, which is the current season now, right? In January, they're all back from their winter holidays. And then, of course, the middle age, or slightly, I would say the young senior group, in their 40s to 50s, starting to feel a little bit of ache in the knee, and are a little bit concerned. And I would say that is a very interesting group, because those that tend to pay attention to it, they seek treatment earlier, we're then able to intervene before irreversible damage happens to the knee. And then, of course, we have those in their 50s, 60s, 70s who come with full-fledged symptoms and signs of wear and tear in the knee, that we can't go back in time, but we have to manage that condition as we deem fit when we see them.
Right. What about you, Bala? Are the people coming in to see physio mainly athletes, or do they tend to be people from a much wider spectrum?
So they tend to be from all walks of life, and I think in this time and age, even the word athlete is it's used more widely. Yeah, with things like high rocks and pickleball and everyone just getting active, which is great. But I think with that, without proper conditioning, perhaps knowing possible preventative strategies, people do get possibly injured more within their own lifestyle and things they want to do. Yeah.
Right.
It's interesting you mentioned conditioning, because I'm sure you would have seen similar trends during COVID, where we had lockdown, and everyone just wanted to get out and be active.
I think I was just like that as well.
So
yeah.
Many accidental cyclists, accidental runners who just
I'm
picked
one
up
of them,
cycling
accidental cyclists.
and running, right, during COVID. And we saw a real uptick in injuries, right, because they were so excited to get active that they forgot that they hadn't done this before, or haven't done this in a long time. And they end up getting like hamstring injuries. We saw lots of ligament injuries, and also cartilage injuries, from overuse. People had, those who were locked down, they were just cycling every day without rest. So when you mention conditioning, it's something that we should really talk about more, because you have to ensure that the vessel, which is the body, is prepared for the journey that we take, drawing parallel from a ship journey, right? The ship has to be prepared for a long journey, and so the body, you have to condition it for you to be able to do a particular sport or activity for the long haul.
Yeah, that makes a lot of sense. Just now you mentioned some people notice these kind of signs earlier and then they went to seek treatment. What kind of treatment do they normally seek?
I don't think they come seeking any treatment in particular. I think a lot of them really just want to know what is wrong with their knee, because they're worried that this is the first time in many years or first time ever that they're experiencing such pain. And, there are many, I wouldn't call them particularly myths, but a lot of old wives' tales, for example, it's rheumatism, it will get better, or it is just growing pains if you're much younger, or, you have wear and tear, you better stop doing it. So a lot of them just want to get proper information and advice from a medical professional or a healthcare professional like Mala, right? And I think we respect that. I think it's important that we take ownership over our body, our health, and get ourselves with the proper information that we need to make a decision. So we don't particularly just advocate for one treatment. When they come and see us, we tell them what their condition is, and there are always options that range from conservative treatment, which a large part of it is physiotherapy. And I must emphasize here that after all these years of advancement in technology and research, when it comes to degenerative conditions of the knee, and you look at the levels of evidence, right? Physiotherapy and exercise together with weight loss ranks as one of the top evidence. That means solid, strong evidence to show that it improves symptoms, right? So we cannot really understate the importance of adhering to exercise and weight control in management of degenerative conditions of the knee. So it's always a start, right? And then we have minimally invasive treatment options, which includes medication, injections, and then of course surgery. I always tell my patients it's always the last resort. If we can manage your symptoms and your condition with physiotherapy, weight loss, as and when needed, medication and injections, that is preferred because it's minimally invasive, little downtime, and as we say, less sometimes is more. But only when these strategies are inadequate to control someone's symptoms, or perhaps inadequate to match their expectations in their lifestyle or their choices of sports that they want to do, we then escalate the treatment to something a bit more invasive and have discussions with them about surgery, again, of which there are many different options.
Right, so what I'm hearing is about knee preservation, about allowing us to use our knees for as long as we can. And it sounds like there are certain tiers to it. And the first tier is exercise, physiotherapy. And then after that, we can add on maybe some injection, something less invasive. And it's only in the worst case scenario then we go for surgery. Is that the natural?
Absolutely. I mean, again, the human mind likes parallelisms. So let me draw a parallel to this. The knee is actually not just a joint; it's an organ, right? It's an organ, right? I conceptualize the knee as an organ, just like how we look after the heart, right? We need to maintain our blood pressure, we need to maintain our cholesterol, we need to ensure we have good aerobic exercise for the heart to be healthy, right? That's a holistic care of the heart. That's what a cardiologist would do. And of course, maintain a healthy lifestyle. Don't smoke. Make sure you keep in check your sugars. So the knee is similar. So when we talk about the knee as an organ, there are many elements that protects the knee, and I draw this in the terms of a pyramid. At the base of the pyramid is your alignment, the alignment of your leg, your lower limb, and that is determined by your bony alignment, and of course the muscles and the forces in the knee dictate the alignment of the forces around the knee as well. And the next is the stability of the knee. And that is dictated by the ligaments in the knee, right? We have two ligaments on the outer aspect of the knee and two inside the knee, right? The cruciate ligaments, the ACL and the PCL. And of course, you have the medial collateral MCL and the lateral collateral LCL on the outside of the knee. They dictate how the knee, how stable the knee is. Of course, if you have an injury to one of the ligaments and you don't seek treatment for it, your knee might be unstable. And the third one is the meniscus. These are the shock absorbers inside the knee that protects the cartilage, pretty much like the suspension of a car. And if you injure your meniscus, you lose this shock absorption. And the last element then is the cartilage, which is the soft covering of the knee, that once you lose, you don't get back. And that really is the goal of knee preservation. Whether it's through physiotherapy, injections, or surgery, we want to preserve the cartilage. Because once cartilage is lost, you can't get it back. So that really is the essence of knee preservation. It's an approach, it's a concept designed to protect the cartilage of the knee through a variety of strategies that seeks to augment your alignment and your biomechanics, that seeks to stabilize the knee, and seeks to ensure that the shock absorption capacity of the knee is preserved. Again, it's pretty much like a car. The alignment in the knee is similar to the wheel alignment of a car, right? And the stability of the knee is akin to the tire pressure of a car to determine how stable it travels on the road. And thirdly, the shock absorption, as I mentioned, is like the suspension. And last thing is really the engine, right? If your alignment is off, your tire pressure is off, and your suspension is off, your engine is going to die earlier than it should, right?
Actually, I have a question for Dr. Hamid.
Yes.
Right? When we talk about the conservative management for this kind of knee issues, it's always physiotherapy together with, or exercise together with weight loss. So similar to, I guess, if there's too much load in the car,
Yes.
you know, things, alignments as well as your tire pressure and everything, they tend to wear off quicker and faster. I was wondering how often is weight loss being kind of addressed within, let's say, a clinic setting, and how successful is it? Because I, in my practice as well, find it quite difficult to broach that topic because they want easier method to resolve their knee pain, when actually I know there are some statistics to show that if there's a 10% weight loss, I think there's a certain number of percentage weight off the knee as well, which helps with the knee pain. Yeah.
Absolutely. I mean, goes back to the first question you asked me as to what drew me towards orthopedics, because it is mechanics. What you see is what you get, and it's very hard to beat physics, right? You know, it doesn't lie. And so you know the knee is a joint that is below your center of gravity, and you know that the heavier we are, the more load goes through the knee. And again, you know, when patients feel it, they are convinced. So the conversation starting is always the difficult. You know, how do you broach this topic about weight with someone? But you know, to me, ultimately we are invested in making the patient better, whether it's through physiotherapy or whether it's through surgery, and it's a partnership. When it's a partnership, it means the partners must put in equal effort, right? Just like in any business, right? So this is how I broach it with the patient. I say that, you know, surgery is only half the deal. You know, I would not offer you surgery if you don't take the first step forward. So I need to know if you are invested in your own health, if you're going to be investing your time in doing physiotherapy, if you're going to be investing your effort in trying to lose a little bit of weight, because weight loss does help in improving surgical outcomes as well. And if someone is not prepared to take that effort to do that, then I'm afraid that no world-class surgery is going to be able to give you 100% good outcomes. It's a difficult conversation, but when patients see that you are invested in them and that it is beneficial for them, they would take that cue and take that effort. No doubt it is not easy at all, right? Some patients are where they are due to medical conditions, and sometimes when it's due to medical conditions, it is hard to just exercise and expect you to lose weight.
Yes, yeah.
And I'm sure a lot of viewers are probably asking this question: I already have knee pain and you're asking me to exercise to lose weight? How's that even possible? And of course, we always say that diet is also part of it. That's one. But again, to address the issue of knee pain, exercise, and weight loss, we do have low impact exercises that one can do reasonably enough, even with knee conditions that would give rise to modest weight loss. Aqua jogging, for example, modified way of cycling, elliptical machines, they are designed for patients with knee pain because these are lower impact aerobic exercises that one can do. But of course, we will not rule out that in some patients, they do need additional help with weight loss. This could be by medication that they take for weight loss, should they satisfy the criteria for being on medication, and some do need bariatric surgery. And in my own personal experience, there have been patients who have been struggling with weight loss, and I tell them, you know, before I do any form of surgery, we need to lose some weight because that weight loss will make the surgical outcomes better. And I refer them to my bariatric surgeon, who then discusses with them the option of bariatric surgery as a bit to lose their weight, because it doesn't just help their knee pain, it helps you beat diabetes, it helps you have a better cardiovascular health, it helps you get better metabolism and hormonal balance in the body as well.
Oh wow, I didn't know weight loss played such a huge role. But now that you mention it, yeah, I guess weight is very mechanical, and our joints are very mechanical as well. And just now you mentioned that some people are worried about overuse. How much impact does overuse affect the joint? For example, one of the things that I've heard before when I was much younger, because when I was younger, I went skiing. I had a very bad fall, so a piece of my cartilage on my kneecap flicked off. So there's a little small hole there. And when I told the story to some much older adults, they mentioned, "Oh, you should stop walking. You should rest more, because if you keep using it, you're going to spoil it." It's like a similar analogy, but I think it was taken really out of context. So they said that, yeah, your knees, they are like a machine. If you overuse it, they'll spoil quicker. And so that put a little bit of fear in me, and so I tried to walk less. I tried to do even less exercise. It didn't get better. Of course, after I saw a physio, they corrected my wrong assumptions. But I'm curious that the mention of overuse, is there a level where if you use your knee too much, it could get worse? And where's that middle ground of not overusing the knee? And where's a good place where I can still exercise and still improve my knee condition?
Yeah, I think this is where I probably need to mention that there is no one-size-fits-all approach. But also there is some truth to it, because the cartilage is like any other material. It's a biomaterial, just like we have materials in manufacturing industries, right? And every material will have the point where it breaks. Whether it's metal, whether it's plastic, you put it through 1,000,000 cycles, maybe at the 1,000,001 cycle, it would break due to this entity that we call fatigue, just like our body, right? You overuse your body, at some point it will reach a breaking point, and you feel it creeping in. The cartilage is like that, right? So yes, there's some truth that, if you keep working it to a certain point, it would break, and that's why we have degenerative conditions like osteoarthritis, where it's due to accumulative use, and also other factors like genetics, like previous injuries you've had, or even metabolic diseases like gout that you might have that may destroy the cartilage due to gouty attacks. Parking that one side, coming back to the topic of how much is too much, it's really quite hard to pin down specifically on average for everyone, but every individual is different. We all have different alignments that we're born with. We participate in different type of sports. We have different muscle coverage around the joints that propel our lower limb. So it really is a function of the holistic assessment of the joint itself, right? Someone might be running, every single day, but at such a low pace that the knee is able to recover and they don't face much problems. Someone might just be running once a week, but they might be pounding their knee so bad that the knee takes more than a week to recover from the amount of trauma that they induce in the knee. So they are polar opposites in terms of the impact on the cartilage. So it's very hard to pinpoint how much is too much. I think the take-home message for your question would be, one should listen to their body and be balanced in everything that they do, right? Too much of everything is obviously not good in all sense of the word, right?
Yeah.
And it's not just in medicine, but even in our everyday life.
Too much of good things is a bad thing.
Yes.
Can I ask, right, for
Yes.
the cartilage, is there a point whereby, so similar to maybe bones, where perhaps the more impact you put, the stronger it gets? Does it apply to things like cartilage and meniscus and
Yes,
so on?
there's this concept of work hardening, that we know from steel, right? You keep hitting steel up to a certain point, it strengthens it, right? I would say to a lesser degree than bone. So bone, we know from Wolff's law that the more weight you put through bone, it remodels and it strengthens itself. For cartilage, less so, but we do know that if you don't put any load at all in cartilage, it would degenerate as well. The lubrication slows down, the cartilage loses its matrix, and it becomes more brittle, which is why we encourage early weight-bearing protocols for a lot of the surgery that we do. We very hardly put a patient off weight for a long period of time, because we have this entity of disuse changes in the knee. You need some weight bearing for compression to happen at the level of the cartilage, for the synovial fluid, which is a joint fluid, to come out of the cartilage, and that is like the normal metabolism for the cartilage. That's how the cartilage exchanges used substances for new substances, right? And we need to encourage that.
Yeah.
So to a lesser extent, I would say it is important, weight bearing, and that really impacts your field of work, which is physiotherapy. And that's why we have a very close communication with our therapists after surgery on weight bearing, when we should initiate weight bearing, when we should withhold weight bearing. There are some instances where you might have known, Bala, that I said, oh, cartilage repair, we can just start weight bearing. And you wonder, isn't this surgeon worried about, the new
Too much
repair
weight.
site, putting too much weight. That's because it also depends on where that lesion is. If it's in the area of the knee that is very congruent, we know that weight bearing helps to actually improve the congruency of the repair, and that synovial fluid that comes is actually nutrients for the cartilage, and it's beneficial. In some other areas where there may be increased shear stresses, then we would say maybe we protect some weight bearing and we would limit the range of motion, because we don't want shear stresses at the level of the cartilage to then damage the repair that we have done.
Bala, so from your time working as a physiotherapist, how do they progress? So I'm assuming they may have come from maybe Dr. Hamid, done some surgical repairs as well, and they have some degenerative condition. What kind of training and what's the timeline that they can expect to feel better and get better, especially if it's a degenerative condition?
So I do see quite a few in that demographic. Maybe they are above 50 with knee pain, coming to see me either post-surgical, or actually a lot of them are non-surgical. So they just come in, who have seen me for other issues, and now they have some knee pain. And usually upon assessment, I can more or less let them know that there is some form of wear and tear that's going on. You know, they have very limited knee flexion range. They can't bend possibly more than 120 degrees. And I'll just be upfront with them that there's, to a certain extent, that physiotherapy can help. But of course, definitely, I think should get an evaluation from a doctor, minimally get an X-ray to see what's the progression like. But I also encourage them that beyond the structural issue that they have, often like the pain, maybe they're coming with 6 out of 10 pain. I feel that perhaps maybe 3 out of 10 could be coming from the joint. Maybe the other 3 could be maybe their biomechanics. Maybe it could be the amount of load, just having that conversation about, are you doing too much too soon? Do you pick up something new recently? That can contribute. And thirdly, it will be like the flexibility of the muscles, the ligaments, the joints as well, which can be improved to some extent, barring like how limited it is because of the structural issues they have. So from the physiotherapy perspective, I try to work on these goal settings, having the conversation about the load management, flexibility, and getting the strength into the knee to help with both the pain and the function of the current status.
So do you find that for most clients coming in, if they do have a degenerative condition, through physiotherapy, do you see them getting better naturally, or would going for surgery usually be the best case scenario?
I think it's always good to have that conversation early so that they have certain expectations, or we can manage their expectations. Like I said, we can get them better to some extent if they perhaps maybe manage their lifestyle. Said, oh, okay, maybe I'm okay with not running anymore. I'm okay to do ellipticals, okay to aqua jog. Then perhaps, you can make it last, preserve the knee for next 10, 20 years before considering other interventions, which, just have the conversation early.
Yeah. And speaking of intervention, so there's physiotherapy, and just now you mentioned one step above that is some sort of injections and other less invasive measures. What kind of measures are those? And should someone seek a doctor out and try and consider these interventions first?
Yeah, so there are myriad of options. I mean, I will just enumerate them before. I don't think this is probably the platform for us to go into detail about all these interventions. I would also caveat that it really depends on your underlying condition and the different parameters I mentioned before. What's your alignment? What's your stability? What's the status of your meniscus and your cartilage? Because if you have bad mechanics, there's no amount of biologic injections into the knee that can help if your mechanics is already wrong. So we have to really be realistic, as what Bala mentioned, right? If you are already having bone-on-bone arthritis all across the knee and your knees are really bow-legged, then an injection might give you a very short-term relief, but the pain will be back again. But in someone who's early, who has some degree of mechanical protection still, and they have very early arthritis, and their symptoms are just mild pain on doing certain activity, then modifying the activity with an injection can give them quite long-lasting, significant pain relief, right? So the first aspect of treatment is really moderating expectations. The reality is here, but if your expectations are there, we'll never be able to meet, right? So if someone comes to me and tells me, oh, do a knee replacement, I'm going to be still running marathons 6 times a year, that's clearly a mismatch between the reality and the expectation, and we need to start on common ground, right? So I usually spend a bit of time with my patients to outline what is a condition, what are the options, and what can we reasonably expect out of each of these interventions. For someone, injections might be a great option in terms of what is available out there, in terms of what we call hyaluronic-based injections, with gel-based injections that are well known, as well as the more emerging biologic injections that are still under study, not mainstream yet, but is showing some promise. And then we have surgery, which again, I'll signpost that there are knee-preserving surgery and there's knee-replacing surgeries. In my philosophy, I always try to preserve a knee when it can be preserved, right? Not overselling it, but to ensure that if your knee is able to be kept natural and it can give you more years, then why not?
That's interesting. You mentioned that there is knee preservation and knee replacement surgeries. Can you go just a little bit more into detail about that? I think as a layman, when I think of surgery, all I think of is take the knee out, put that metal thing in, and that's all that I can do.
Yeah, knee replacement is a great surgery, when done at the right time for the right patient. So individuals, Singaporeans are very active, as we know. Age is now just a number. We have people living up to their 90s and are very active. So what used to be the norm, where someone at the age of 65 or maybe even late 50s goes for a knee replacement, today you would think, oh, wait, that's a little bit young.
Yeah.
They're living up to the 80s. And we know from common knowledge and even studies that we know that a good knee replacement can last perhaps 20, 25 years. So if we do it at 55, 50, then in your 70s, when you are probably fairly active, you're going to be needing another knee replacement. And what we do know from science is that the second knee replacement can never be as good as the first knee replacement, because it's going to be more complex surgery. You're going to be losing more bone when we remove the metal, and we're going to be putting more metal inside, which means the knee feels less natural. You'll get less out of it, and there's a higher risk of complications like fractures, infection, and whatnot. So the aim is really to delay the first knee replacement for as long as reasonably possible, so that everyone should just need one good knee replacement in their lifetime and get the best out of it. So that's the overarching objective of knee preservation. It might sound counterintuitive that I'm preserving the knee to do a replacement, but it is true. We are preserving the knee. Of course, the gold standard is to preserve the knee such that it doesn't need a replacement anymore. And we are able to achieve it in some patients when they come early. But the other aim that we speak less about is I'm teeing myself up for a successful knee replacement later on in their life. When they come a little bit later, with a bit more moderate arthritis perhaps, but they're still too young for a knee replacement.
Right.
And we think of, okay, how can I get more years out of your knee? It's just like extending the COE of a car, right? If you find that a car can still go and it's wasteful for you to scrap it, you would think, is it worthwhile extending it by 5, maybe 10 more years? That's exactly what I do as a surgeon. Can I get more years out of these knees COE? And if yes, then that gives them 5 more years of good lifestyle with their natural knee. Maybe that means from 65 to 70 years old for a knee replacement. That could mean delaying a knee replacement in someone in their 40s or 50s. Right? That's really the concept of knee preservation. And ultimately, it's about giving patients the information they require for them to make an informed decision. I'm sure if you were a patient and you were told for a long time that knee replacements are the only option, and suddenly you are being told that not really, there are other options, but they come with pros and cons, and you make the decision what is good for your lifestyle and what you want to achieve.
Yeah, so it really depends on the individual as well and how they want to live their life. If they want to be active, or are they going to be more sedentary, maybe just go for walks versus someone who's trying to run again.
Absolutely.
And that will probably change what type of surgeries and what type of interventions that they are looking for.
Yeah, and some are just looking for pain relief. They don't really want to go under the knife, and there are many pain relieving modalities, of which some are done by the therapist in terms of ultrasound, shock wave, and again, so much to talk about pain because there's so many pain generators. Right? Pain in arthritis might not just come from the joint itself. It might come from the muscles. It might come from stretched ligaments. It might come from entrapped nerves. In fact, another joint might also be affected or overloaded in patients with knee arthritis, and they may have hip pain due to hip muscle overload, for example. Right? A lot of them have glutes pain because they're overloading their hip abductors because of the malalignment of the knee. So there's just so much for us to unpack and discuss with patients. And I think the core message is one should know what are the options they have and what they can achieve out of each option, and whether that is something that is of value to them. It's pretty much like shopping. Right? When we go out and we look at so many options of shoes to buy, you will be looking at what is the cost of it, right? How does it look aesthetically? and whether I feel comfortable in it. And I think ultimately patients need to be comfortable with the decision that they make. Ultimately, knee preservation is about augmenting alignment, stability, shock absorption in a bid to protect the cartilage. So first thing is the alignment. If someone is malaligned and the alignment can be salvaged, that's our preferred option. We want to realign their knee so that we better distribute their weight across the knee. So for example, if one compartment of the knee is damaged and there's another healthy compartment, we want to drive the force away from the unhealthy compartment to a more neutral position so that that compartment doesn't give them pain. Of course, you cannot ignore stability and shock absorption as well. As much as possible, if the patient has an unstable knee, we want to address that, and that usually is by way of ligament reconstruction.
Right? Ligament reconstruction.
Yeah, that's right.
Okay.
And if the meniscus is torn or degenerate, we can look at ways of stabilizing it and repairing it so that it restores not the full, but at least some shock absorption capacity. However, research shows that mechanics trumps everything. If you have a good alignment, even if your stability is slightly compromised and even if your meniscus is slightly compromised, patients still do get better just from the offloading. Because even if it's a diminutive meniscus or a degenerate meniscus, because you're putting less load through that meniscus, it's able to cope. And don't forget, with physiotherapy, we can then build muscles to also compensate for it. So it goes hand in hand, right? Everything is holistic. They're like a symphony orchestra, right? Every player contributes to the final music that we hear.
Right. So now it's not just about just replacing the knee. There's all these other smaller interventions that we can do.
I wouldn't particularly call them small. They are, of course, surgeries. They are just conceptually different. So we're not replacing the cartilage with metal and plastic. We are keeping your own cartilage, but giving it less work to do by augmenting and addressing the alignment.
That's interesting. I didn't know that there were surgeries that could actually help with alignment. So it's great to hear that there are other alternatives as well. Now, let's say I'm someone who is in their 30s and 40s. Let's just assume that I'm still young. I don't have the knee pain yet.
Yeah.
Oh, that's going to be my age soon. So I'm also curious. So I have no knee pain yet. What can I do as of now? I'm someone in mid-30s, mid-40s. My knee's fine, and I hear this knee preservation, and I want to preserve my knee. What can I do from a orthopedics perspective and like a physio perspective?
I think Bala should take this question first because they should really not be seeing me if they're not in pain and not having any symptoms.
Yeah, correct. So I think one thing to address, right? Like I think there's also maybe over diagnosing. Right, so sometimes maybe we hear certain things. Oh, you can get this bad. People are having this pain, and so everyone is different. Everyone's knee is different.
Yeah.
So I guess if you don't have any knee issues, you should be continue to be as active as possible. Do your strength training, be flexible, and that will probably give you the mileage.
Right. So it's really just about strength training.
Strength training, being flexible enough, and being progressive in your load. You know, don't do anything too much too soon.
Yes.
Right. Don't overload the knee.
Yes.
Right. So those three.
Which applies to any joint or body parts. To say, but I always index also like to not overthink it. So because we hear stories, then we feel that it's going to happen to my knee, then we kind of move differently.
Yes.
Then our biomechanics change. Yeah, like similar to like some of my guys, they come in like post ACL. And we done the rehab, we done like 9 months, 12 months even, right? And they are good. But then when they want to go back to sport, then they're like, oh, I'm going to wear my guard, I'm going to tape up my knee, I'm going to double strap it. And so it's like, dude, if you feel like you need to do that, you're probably not ready. Like the doctor has done the job to like stabilize it, right? So you should be confident enough to, because otherwise there's statistics to show that you can get injured on the opposite side after coming back from a knee surgery, right? That's often to do with the biomechanics because you are over-relying on another joint at this point in time, yeah.
Right.
Yeah, it's very interesting what I mentioned. I mean, the impact of the mind cannot be understated as well, cannot be overstated as well, you know. Many a times you overthink it, and then if you're not having any knee pain, there's really no need to be over-cautious about anything. I think simple things actually make a lot of sense. Just maintaining a healthy diet, doing what is needed to keep yourself healthy, and to address these things that are just very intuitive, right? Obviously, if your BMI is on the wrong side of the scale, you want to work on that by eating healthier and getting more active. If you're not having knee pain, it's good. And I think one of the things is gaining more traction in recent years is the concept of sarcopenia, right? Age-related muscle loss. And that's something I think we should talk about when it comes to knee preservation or any joint preservation, that we naturally lose muscle as we age, and I think resistance exercises becomes very important. And I think conceptually when a layperson thinks of exercise, they just think of aerobic exercises, running, swimming, cycling. But there are two other types of exercises that we often don't really talk about. Maybe resistance exercise and weight training is getting a lot more popular these days with lots of accessibility to gyms in our common living spaces. But the third thing, flexibility exercises, really needs to be talked about more.
Flexibility
right?
exercises.
Your joints need to be flexible, right? Otherwise, your joints get stiff, and stiffness is a problem because when you move against a stiff joint, you create injury. That's when you tear ligaments, that's where you tear tendons, and then you upset the equilibrium and the balance of a joint.
Yeah. Wow, I just realized that I'm actually very inflexible. So maybe after this, I gotta go and get some flexibility exercises.
So which is why things like yoga, Pilates are
Correct.
getting more important to speak about.
Yes.
Yeah. So 3 types of exercises one should have in their sort of, you talk about a healthy plate where you need to have carbs, protein, and vegetables. Same thing for exercises. You need to have aerobics, strength, and flexibility.
Aerobic strength and flexibility. Nice. I like how you've always compact all of these ideas into very easily digestible.
Digestible.
Yes, I'm a metaphor junkie. I just like to give metaphors to make things easy.
That's good. I really like how you talked about the alignment, the stability, and how you related that to the car.
Yes.
Helps me visualize it, and then I'm able to remember it. It's going to be something that I remember for a long time now. Thanks so much. Okay, there is a few questions, or I would say a few statements that I've heard and a few of my friends have heard, and I want to know how true or whether it's something to be of concern. For example, one of the things that I've heard a lot recently is, hey, my knee's popping, or my knee is a bit of a cracking sound, and they just start extending their legs. And they're like, oh, do you think it's like broken? Like, can I still go for a run? Can I still go for the hike? Yeah, especially just recently, I was about to go ski with my sister, and she also mentioned, oh, I have this cracking sound in my knee. I don't feel safe. What do you think about that?
Yeah, so that in medical terms called crepitus, right? And a lot of our joints make noises. They are actually normal. They are due to tissues moving, as you move the joint. As long as that crepitus is not associated with another more sinister symptom like pain, swelling, or even a joint moving in and out that gives you a little bit of apprehension or this sense of fear, you're okay, right? There's nothing really to panic about. So you should only really be concerned if the crepitus is associated with some other symptom that then you should seek medical assessment.
Okay. So all these cracking sounds is actually normal, and it's just part of our body mechanics as well.
I wouldn't particularly say mechanics. That we have tissues, across joints. They can be muscle, they can be what we call fascia, and they move, as we move the joint. And some of them just rub over the bony surfaces and they create noises.
Right. So we should only really look into it and be I wouldn't say be afraid, but to maybe be more concerned about it if there's some other sinister symptoms like pain, for example.
Swelling. Yeah.
Pain and swelling. Yeah, so swelling, if I'm doing a certain exercise and my joint starts to swell, is that a cause for concern?
Yeah, it really depends on the context. If you're running after 20 years of not running, then you might expect the knee to react a little bit. So I think that's almost expected. If you just had surgery a few weeks ago, then swelling is absolutely normal. And of course, if you have a known condition that causes swelling, then we know what's the cause of it. For example, if you have rheumatoid arthritis or a condition like gout, then you can expect that a gouty attack or a rheumatoid flare might cause swelling. Otherwise, any persistent swelling in the joint, right, it's due for concern and should be evaluated for any underlying problems. I always advise patients, if you see a bit of swelling, just rest, ice, compress and elevate, the RICE therapy as we call it. And if it persists beyond a week or 2, then you should seek a medical opinion.
All right. So for crepitus, you mentioned crepitus, that isn't too much of a concern, but swelling might be more of a concern.
Yes.
All right. I feel like these are the two things that I've seen a lot. So I rock climb, and sometimes after we rock climb, some of our friends have really, really swollen joints, and they get really afraid. Some of us, our hands and our fingers also start to make a little bit of a sound, and so we're not very sure like what we should be concerned about. But it's good to know that swelling generally means that there might be something that we could look into. Maybe we tore something. If it's just a little bit of a creaking sound, most likely it's just the natural movement of the body. Right. All right, thanks so much for that. Okay, thanks so much for today. As a closing thought, I think it'll be very good to hear from you, Dr. Hamid, as your work as MP as well. So you will probably have a much broader perspective of not just on the knee, but in healthcare in general. So in the next 5 to 10 years, how do you see the future of, well, we could start with knee preservation and how it's going to develop, and maybe like healthcare in general?
Yeah, so I think we're in the realm of precision medicine, right? Where we are looking at what an individual requires for him to actualize his potential in health and wellness. And I think this will pick up in a big way in the next 5 to 10 years with the application of AI, precision diagnosis, and precision medicine. Another aspect that we're looking at is what we call gero medicine, right? Not geriatric medicine, which is treatment and assessment of older individuals, but gero medicine, which is a study of aging in general. Believe it or not, like it or not, the moment we are born, we start aging. Our cells age, our joints age. So gero medicine basically is looking at how to optimize an individual's potential at that specific point in time so that he gets the best out of his body. And these two concepts are important to bear in mind, not just as healthcare professionals, but also as individuals as we seek to make the best out of our life that we have on earth. And I think this will shape the way we practice medicine, right? That means it is no longer going to be textbook material where we just slap the same knowledge on every individual that we see. It's going to be something really specific to you, right? Alvin, it's going to be very specific to you, Bala, because your knee is of this age, your biological age is this, your physiological age is this. There's a little bit of a gap, and I think you need this to be done for you to be able to optimize and maximize your potential. So I think that's what I have to share, and I think this will also shape the way I practice orthopedic surgery, where, we always use this analogy in public health, everyone's gun is loaded. You just don't want to pull the trigger. And that refers to our genetic potential. There's genetic potential, and also there's genetic aberrancies that all of us carry. Some of us just are more prone to certain diseases. And if we're able to unlock that information, to know that, yes, you are more prone to this sort of musculoskeletal problem, then I want to intervene early and make sure that we don't pull the trigger too early. Maintain your weight, strengthen the muscle, because you have a gene that would then cause you to have early arthritis. For example, this is just an example, but I guess you get the drift, right?
Yeah.
Opposed to before, where we just say, yes, everybody just maintain a healthy lifestyle, you eat well, maintain your weight, but you might need to be in a weight category that is far more protective for you than someone else who could maybe afford to be a little bit heavier because they probably need more muscle for some other condition they may be at risk for. Right, so it's exciting, at the same time it's very complex. But I think things will get more refined as we go along, as technology matures and as knowledge widens. I think we hope to think at least that we will make the best use of the knowledge and the tools that are available to us.
Nice. That's actually very optimistic for me to hear. Learning that people are looking into aging. As you mentioned, every one of us are aging.
It's aging in motion, right? Yes. We have aged like 45 minutes from the time we started this podcast. Yes.
Yeah, so it's great to hear that things are moving forward. And thank you so much for today, giving us your insights.
Oh, it's a real pleasure. Thanks for having me. It's always a pleasure to share what I've learned, and I continue to learn. So till next time.
Yeah.